Good afternoon, everyone. Welcome to Medicine Grand Rounds. Welcome back and Happy New Year, Happy 2024. I am here to introduce our first speaker of the year at Medicine Grand Rounds. This is a special visiting professorship from the UCSF Division of Endocrinology. We're going to talk about two of the most common diagnoses and how they intersect: heart failure and diabetes, from clinical care guidelines to implementation. To introduce our speaker today, we have UCSF Endocrine Division Chief, Dr. Sunil Kaliwad, who's going to do the special introduction of our visiting professor, Dr. Radhika Papusui. Thank you so much.
Thanks a lot, Lakshmi, and thanks to everybody joining virtually, as well as folks who have come to see the talk in person today. It's a great pleasure to have today's speaker. Those of us who take care of patients frequently with diabetes, the first thing that we really sit down and start talking to our patients about when we're trying to generate enthusiasm, generate motivation, generate a therapeutic alliance with us, has to do with the inroads that we think we can make with our patients, specifically with respect to complications. Because at the end of the day, that is what our patients would like to see never manifest, and that's our goal on their behalf as well. And with that idea, that seminal goal in mind, I think there's probably nobody more so focused on this area nationwide than Radhika Papusui, with respect to translating what we've learned at the basic science level with respect to how diabetes leads to specific complications that are prevalent and really costly in many ways to humankind, into translation to clinical practice and how we might do things differently to specifically mitigate those risks. And a lot of the stuff that trainees these days take for granted about what we actually think of as second nature with respect to what the goals of management are for diabetes have come from seminal trials that Radhika has been a key member of. And that dovetails into our current era, in which we now have a much larger armamentarium of drugs to choose from that have the ability to reduce risks for specific complications, both by reducing hemoglobin A1C and improving glucose control, but also independently of their ability to specifically improve glucose control. And that latter issue is, I think, really, really relevant at the intersection of diabetes management and heart failure, because some of the really interesting drugs and drug targets have the ability to improve cardiac function in very interesting ways. And so with that, we are really looking forward to hearing Radhika's thoughts on the intersection of heart failure and diabetes and new vistas, which are really exciting. And if any of you would like to hear about neuropathic complications, Radhika is going to be speaking at the Diabetes Center seminar, which is going to be held in a special time today at 4 p.m. And again, that's another rich area where science and translation is taking place. So Radhika, thank you very much. Oh, and one last thing, in recognition of all of this leadership over a career, in many ways, Radhika was elected and is currently serving as the president of medicine and science for the American Diabetes Association. Richly deserved. So thank you for coming and speaking to us in many venues over the course of the last 2 days.
Well, thank you so much for this very kind introduction and for the kind invitation to visit UCSF. I have never visited the UCSF campus, although I have been in San Francisco many times, and it was thrilling to interact with so many of the endocrine colleagues and also vascular surgery colleagues yesterday and the fellows, and I'm very thrilled now to be part of the internal medicine grand rounds. Just a quick correction, I have been elected the 2023 President of Medicine and Science of the American Diabetes Association. So I just finished that, but I continue to be part of the board of directors involved in many aspects. And I'm going to talk to you today, as it has been shown, about two very important clinical care and also research components: diabetes and heart failure, and how to link the guidelines to clinical care implementation. And here are my disclosures. What I'm going to do, I'm going to actually give you a brief epidemiology overview. because you need to see the data that highlights the importance of heart failure in diabetes, and then go over some mechanism, diagnosis and stages, management and care implementation. So to put things in perspective, and here we are not in the endocrine division, we are in internal medicine, but it's so relevant because diabetes is perhaps the most challenging chronic disease here in United States and worldwide. And these numbers that you see here speak for themselves. In fact, all our projection for diabetes prevalence and incidence worldwide have continued to be outnumbered by the actual data that the International Diabetes Federation is updating every year. And here, if we look at the most recent national statistics report in United States, with 15% of Americans being affected by diabetes, this is a huge challenge, and we need to do much more. And the reason is that this is the consequence. The costs for our healthcare system in US only are non-sustainable. And what drives this cost are, in fact, the presence of many of the complications and the impact that diabetes has on the human body, from more traditional complications that we used to concentrate when I was doing training, so-called microvascular complication, and more recent complications that actually demonstrate that diabetes can affect the entire human body, including psychosocial, mental disorders, cognitive impairment. For many years, and even as we speak, the cardiovascular complications have, placed the center role. And one of the goals in my career, and also leading many of American Diabetes Association initiative, was that we really need to fight and change the course. Now, before delving into the actual data, let me show you two cases. One, it's a 60-year-old man with type 2 diabetes, obesity, hypertension, who presents for routine follow-up. He has no known cardiovascular disease, no specific heart failure symptoms, does complain of short of breath with walking up the hill, and has no other signs of heart failure on examination. And the other one, it's a 50-year-old woman with type 1 diabetes for 30 years, with hypertension and chronic kidney disease stage 3A, with a very similar clinical presentation. And I want you to think about this question while we are talking about, are there any specific screening tests that you would order for these patients, except of course A1C? And then I want to give you a little bit of historical perspective, because it has a lot of meaning with San Francisco. In 2019, as a matter of fact, I was leading the cardiovascular interest group for the American Diabetes Association. And we were here in San Francisco at the annual scientific session. It was a packed, I think we had one of the largest attendance, over more than 17,000 participants. It was before pandemic. And in front of this full house of endocrinologists, diabetologists, even many primary care physicians, general internal medicine in that room, there was a question that was asked to us. And that was, how can we, clinicians at large, not cardiologists, understand whether people with diabetes are truly at risk of heart failure? Are there any signs? What do we need to do? Because a lot of data has emerged about this heart failure with preserved ejection fraction and how this can be a problem for our patients with diabetes. But by the time that a person with diabetes sees a cardiologist, it's so late. So these people ask us, can you guide us? Can you do something about that? And then we were very fortunate as I applied, and American Diabetes Association has agreed to allow us to work as a group and convene a very expert groups of endocrinologists, cardiologists from American Heart Association and American College of Cardiology, Dr. Jim Januzzi from Harvard, who was elected to be the vice chair, and Dennis Brumer from Cleveland Clinic, as well as several nephrologists and several primary care physicians. And I'm going to highlight that because with 37 million of people with diabetes that we currently have here in the United States, This is not manageable by us endocrinologists. It's not manageable by our cardiology or nephrology colleagues. In fact, our role is to educate our primary care physician, general internal medicine, to understand what diabetes means and how to best manage and screen people with diabetes. And I'm not going to go through everything that we unpaid. It was a 3-year work. We had access to the largest cohort of epidemiologic follow-up, starting with Framingham and hence here in US, as well as our European colleagues, the Swedish, Scottish registries, to name just few, clearly unveiling that, to our surprise, heart failure is in fact more prevalent than atherosclerotic cardiovascular in people with diabetes. In fact, if we look at this study that looked at 6 national cohorts of people with type 2 diabetes who were free of both renal and cardiovascular disease at baseline and were followed up to 5 to 6 years. When we look at the cardiorenal disease, which is either heart failure, CKD, or both, as you can see here, the incidence rates are the highest when compared with other forms of atherosclerotic cardiovascular disease, such as MI, stroke, or peripheral arterial disease. Another huge surprise was because, of course, we said, well, yeah, that's driven mainly by people with type 2 diabetes, all this large data set. But in fact, we've learned, and again, our European colleagues who have these phenomenal registries in which they follows their population from birth till death. This is just one example in the Scottish registry that followed more than 3 million of people, that type 1 diabetes actually is associated with a very high risk for heart failure. And what was even more unexpected was that this risk is even higher in women. So in general, it is known that in the population, women have a lower risk for cardiovascular complication than men, a situation that is not at all the case in diabetes. And to our surprise, particularly in those people with type 1 diabetes who had no evidence of ischemic heart disease, the risk for heart failure was very high. And these are facts, again. All these cohorts are outlined in the consensus paper that was published in Diabetes Care in 2022, and it's free for everybody to access. We also have learned that, in fact, the incidence of diabetes among the heart failure population is much higher. And again, those are very established cohorts around the world demonstrating an increased risk in diabetes incidence. Why is so important? Well, when we look at the impact of diabetes on prognostic factors, here you see that even in a combination of known risk factors for more severe disease, the diabetes per se increases the risk of severe complication by 30–40% when adjusting for hypertension or known atherosclerotic cardiovascular disease, for instance. This is also data from the very famous ARIC, atherosclerosis risk in community studies, that show that there is also an exponential link with A1C levels, and then that in diabetes, based on A1C, the risk of heart failure occurs at much younger ages than in people without diabetes. Again, all this data, it's in the consensus, and in fact, the mortality rate in people with diabetes and heart failure here is shown as seen here. This is a very large cohort of more than 115,000 adults with diabetes that were followed for 5 years. And as you can see here, the mortality in those with incident heart failure is enormous. And that's older data, almost 20 years ago, but that was further confirmed in other 2 large landmark cohorts, the LIFE trial on the left, RENAL study on the right, demonstrating again the same thing. In red, people with heart failure, with diabetes; in blue, no heart failure. Again, mortality rates are substantially, exponentially higher. So, of course, the question is, what do we know about the mechanisms and why, even people who don't have known ischemic heart disease develop heart failure? What can drive these changes? And then that could make the entire talk today. So I'm just going to highlight something that is more specific in diabetes. We've learned also during this consensus that there are multiple potential mechanisms, that links ER stress, mitochondrial dysfunction, inflammatory pathways. But I like to highlight two that are specifically relevant in diabetes. And one is this metabolic lipotoxicity, especially understanding how important is this shift between free fatty acids and glucose in the heart metabolism. And actually all the knowledge that we have is due to elegant studies that our colleague Dale Abel has done initially in experimental models. And here are some of these studies clearly linking glucose and lipotoxicity in significant metabolic changes in the heart in diabetes that can lead to that progressive dysfunction. And then actually sharing some studies that I was fortunate to do myself at Michigan, where we're able to perform very elegant imaging for both autonomic dysfunction as well as oxidative metabolism of the heart and linking them to MRI, and identified, in fact, that women with type 1 diabetes who have no evidence of ischemic heart disease have a significantly lower efficiency of the myocardial contraction due to these changes in the oxidative metabolism of the heart compared with men with type 1 diabetes. So that can, again, a link to this higher risk of heart failure in women with type 1 diabetes that has been now reported by several large individual cohorts. And another unique aspect in diabetes is the presence of the autonomic dysfunction. And the link between the sympathetic and the parasympathetic function with heart, including metabolism and function, has been demonstrated in many models. And then again, here we had the opportunity to look by performing this, state-of-the-art imaging that University of Michigan had developed and validated to image the sympathetic nervous system of the heart, and showing that the more sympathetic denervation is associated with changes in the diastolic function in people with type 1 diabetes, even if they were completely asymptomatic and have been free of ischemic heart disease. And although that was a small study, we had the opportunity, in fact, to phenotype the entire DCCT EDIC cohort. And I spoke about the multiple lessons we've learned from this cohort. But something that I didn't say yesterday is that at some point we did perform cardiac MRIs in the entire EDIC cohort, where at the same time we perform this entire gold standard battery of cardiovascular autonomic testing, and identified, in fact, a phenotype of people that had autonomic dysfunction that already had impaired left ventricular remodeling as assessed by this mass to volume ratio and increased left ventricular mass. And in fact, with our statistician, we had about 900 people in which we were able to do these studies in EDIC, identified that having cardiovascular autonomic neuropathy was a significantly higher risk factor of developing these changes in the left ventricular architecture than an increase by 5 millimeter mercury in systolic blood pressure, for instance. So those are just some mechanistic aspects for our residents and our colleagues as food for thoughts. Now let's talk about clinics and guidelines and evidence. Well, many of you, of course, who are cardiologists know that AHA and ACC have changed the way that they are staging heart failure. And we are now talking about this subclinical stages, stage A or at risk, and stage B or pre-heart failure. And then they identified, of course, some specific phenotypes that are associated with each of these stages. And then that, unfortunately, majority of patients who get to be seen when they get to the hospital, they are already in stage C or D, right? Which is an advanced form. Now, as you can see here, diabetes, it's now part of this at-risk phenotype of stage A heart failure. And why is this important? And I think that we are living in very how can I say, good times for us as clinicians and researchers is that through lots of work, there is now the capability of identifying people in stage B, which has already structural heart disease and are completely asymptomatic. And is obviously associated with this elevated filling pressure through now biomarkers that have been shown to be sensitive and specific to identify exactly this stage. And I'm going to share with you now the data that we had the opportunity to review during the consensus, especially since many of our colleagues were part of some of these trials that had the oversight to collect biosamples and assess some of these biomarkers from baseline and then link them to outcomes in many of these cohorts. And then again, I'm not going to go through each of these particular studies. They are all listed in the consensus, but I'm just going to share with you some so that you are convinced that now some of these biomarkers, and particularly the natriuretic peptides, are not only available for testing, but they do carry important prognostic information. Here is, for instance, one of such studies that included more than 1,000 people with type 2 diabetes. And we all know that for many years, albuminuria, which was originally thought as being an important diagnostic marker for chronic kidney disease, in fact, turns out to be even more prognostic for cardiovascular risk, right? But here is this cohort in which both albuminuria and the NT-proBNP were measured at baseline, and they were followed for approximately 33 months, with the primary outcome being hospitalization for a cardiac event or death. And as you can see here, in fact, as shown in the this dotted dark line, a threshold of an NT-proBNP at baseline above 125 was associated with the highest risk of predicting hospitalization for heart failure in these patients, much more so than albuminuria itself, and there was basically not much addictive information when the two were linked, although there was a little bit of synergy. Another study, this is actually a larger cohort. Here we are talking about more than 5,400 people with type 2 diabetes, and this was a secondary analysis of another famous cardiovascular outcome trial called ELIXA, that some of you may be aware, that looked at lixisenatide, GLP-1 receptor agonist. They had again measured the NT-proBNP at baseline and then followed these patients for up to 26 months. And what is relevant here, it's even when we look here side by side, people had no known heart failure at baseline. Those who had known heart failure at baseline, an NT-proBNP level that was elevated was actually significantly associated with hospitalization for heart failure, predicting, actually hospitalization in the following 6 months. So there is a biomarker, so all this data that has emerged identify a potential biomarker that we can use at the point of care to identify people who are at risk of, being admitted in the hospital 6 months or longer down the line. Now, of course, when we try to do guidelines, we know very well how guidelines are being judged, right? And how we grade the level of evidence. And we need to have actually some intervention trials that tell us, okay, if I do this screening and I spend all this money, what's the evidence that I can do something that will actually change the course? And I'm sure that my colleagues cardiology in the audience are very familiar, but we are the entire internal medicine family here. And here is the Pontiac trial, which actually looked at participants with type 2 diabetes and had been phenotyped with this NT-proBNP and had been selected this threshold of 125 based on some of the evidence that I've shown you, but there was more, to select this threshold. And they were randomized to either a control group, which was cared by for their diabetes as usually through their diabetes care unit. But then the intensified group was additionally treated as a cardiac outpatient clinic, and trying to optimize all these guidelines for heart failure at time, including optimizing RAS antagonists and beta blockers. This was, as you can see, done before other effective medication for heart failure were available for the diabetes population. And again, the endpoint was hospitalization for heart failure after 2 years, clearly demonstrating that this intensified approach by just adhering to the guidelines, optimizing RAS and beta blocker was effective. Based on that NT-proBNP of about 125 to mitigate the risk. Here is the STOP Heart Failure trial, more along the same line, those 1,300 participants with cardiovascular risk. Again, they were randomly assigned to receive either primary care control, those were not necessarily with diabetes, and being screened with BNP levels, different threshold. It's a slightly different biomarker, right? And then they were followed to see whether they need an echocardiography, and then there was a collaborative team care between primary care physician and specialist cardiovascular disease. Again, demonstrating that people who are at risk for heart failure based on biomarker assessment, actually a team effort between primary care and cardiology is not only feasible, but actually leads to better outcome for these patients. And what is actually even more interesting is that, and it's so relevant to the way that we can practice medicine today, because yes, we are overwhelmed. I mean, the waiting time to get in our specialist clinic is so high, but there are also these aides that can participate in care. And here is an example of a pharmacist-driven team approach for screening for this biomarker, and then unveiling therapeutic and management approaches based on a clinical pharmacist as the primary team member to address this screening. And I also want to share with you data that demonstrates that serial measurement in these biomarkers are important, because even a 25% increase over time, especially if optimization therapy is not, it's not initiated, carries a very substantial risk, as you can see here. More than 90% increase in risk. And this was a community study of more than 9,000 people, demonstrating that repeat assessment can also give you important guidance of how to optimize or adherence to therapy, and making sure that then you take the next steps. So based on a lot of this evidence, and much more that it's included in the consensus, we actually came with this stepwise approach for the evaluation and diagnosis of heart failure in diabetes, and also identified some specific phenotypic characteristics that would unveil those people who should more likely to be screened first, because definitely we will not be able to screen all people with diabetes with an NT-proBNP or similar biomarker. In fact, we also find that the high sensitivity troponins are pretty sensitive in specific, particularly in the obese population, where it's known that the NT-proBNP levels are much lower. So, and then again, this is a much more nuanced approach, but to summarize this part of the consensus, it's actually, and it was unanimous between all of us that were there, that the data was so convincing that we feel that we need to recommend that people with type 1 diabetes, who have also additional risk factor, particularly obesity, hypertension, and some form of kidney dysfunction, should initiate a proactive screening with these biomarkers when they are being seen in clinics, with now, of course, NT-proBNP having the strongest body of evidence, but also with troponin in some specific cases. And they should be screened at least once a year if they are normal. And if they are elevated, of course, we developed a stepwise approach on what would be the best steps. Of course, there was a lot of concerns among cardiologists, where if we do that, and we are going to be overflooded with referral, everybody will not see a cardiologist, that's not feasible. And I'm just going to walk you through some of the steps to demonstrate that, in fact, through this STEAM approach and through education of primary care and all of us endocrinologists, that may not be necessarily true. But it's good to know that as soon as we published that, AHA and ACC decided that that's absolutely true. The evidence is there, so they updated their guidelines for the management of heart failure in general, but they have put here a specific line for diabetes. And in fact, our consensus was endorsed by the American College of Cardiology. Since then, additional societies have seen the evidence, and the Diabetes Technology Society, and more recently we worked with our cardiology colleagues in Europe, who were very excited about the consensus, and they recently updated the European heart failure guidelines and included these specific guidelines for people with diabetes screening using natriuretic peptides. And then now the 2024 American Diabetes Association Standards of Clinical Care specifically updated the cardiovascular disease risk management, recommending screening of adults with diabetes for asymptomatic heart failure by measuring a natriuretic peptide to facilitate the prevention or progression to symptomatic stages. So why would we do that, you would ask me? And again, we are so fortunate because not only that we have developed these biomarkers that are so easily measured at the point of care, but all the explosion in knowledge in diabetes treatment, and particularly on the benefits with respect to cardiorenal disease prevention, are also available to us today. So therefore, in the consensus, we also wanted to make sure that we do not leave clinicians in the air, but let's give them a practical approach. What do you do if you have an elevated NT-proBNP in someone who had no idea they may have heart failure? And here are, the steps that we have also included based on evidence. And unfortunately, as we were also talking yesterday, the standard of clinical care does not automatically now say that if you have type 1 diabetes, you need to be treated with metformin first and fail metformin. Everything is now done in a more personalized approach. And in that particular case, we were very vocal. Some colleagues said we should not be so, how can I say, categorical, but yes, we should, because in the presence of evidence of stage A or B heart failure, an SGLT2 inhibitor should be an expected element of care for these patients because of all the large body of evidence that these agents have demonstrated in preventing death or hospitalization associated with heart failure. But this is more to that than just SGLT2 inhibitors. We are not promoting SGLT2 inhibitor. We are also identified that there are, in fact, some agents that have been and continue to be used for treating people with type 2 diabetes that may, in fact, have detrimental effect, particularly in potentiating heart failure risk. And the TZDs are notorious, and so are some of the DPP-4 inhibitors, not all of them, but still. And when one has to choose between expensive medication, non-generic medication, some that have proven cardiorenal benefit in addition to glucose control, and others that have no necessarily harm, but definitely no benefit, that's something else that we need to keep in mind when select a medication to treat our patients. And now, although at the time of the consensus, the evidence for GLP-1 receptor agonist was not there particularly for heart failure risk reduction, again, and I don't have the slide here, but a couple of weeks ago, we, for the first time, published the SELECT trial, which was, evaluating semaglutide for cardiovascular risk reduction in people with obesity, not diabetes, but demonstrating a 20% risk reduction in the risk of hospitalization for heart failure with the GLP-1 receptor agonist, which further, increase their benefit in addition to a benefit in preventing atherosclerotic cardiovascular disease risk. And then again, we also provide some guidance on how insulin should be given, or of course, to avoid hypoglycemia, which in people with heart failure, again, to this interplay between hypoglycemia, autonomic dysfunction, and metabolism in the heart could trigger arrhythmias that are not needed. However, as I mentioned earlier, and it has been demonstrated, for instance, by Pontiac, it's surprising that people with diabetes may not be even optimally controlled with RAS blockers such as ACE or ARBs, or not having optimized blood pressure control. So therefore, the consensus clearly shows all these steps. Are their blood pressure optimally controlled? As a PCP, are you giving an optimally titrated ACE or ARB to these patients? And if that, are they still on a TZD or perhaps one of the DPP-4 inhibitors who have shown clear that they have potential of increasing heart failure? If yes to all of this, they should be put on an SGLT2 inhibitor. And now more recently, we have an additional agents that has shown clear benefit, finerenone and MRAs, agonists that demonstrated benefit in people with type 2 diabetes, chronic kidney disease, particularly on heart failure outcomes. There are other more nuanced medication for those with reduced ejection fraction, including sacubitril valsartan, the MRAs, that I know are a little bit less comfortably handled by primary care or even by some of the endocrinologists, but the evidence for these agents is there. Another important aspect is that definitely lifestyle intervention remain very important in people with heart failure, so they should continue to be promoted, and lifestyle such as exercise, smoking, alcohol, dietary management. We do have very nice tables in the consensus that actually walks you through some of this dietary management and salt reduction that have been instrumental, in general for people with heart failure. And then I think that for the first time, we have also been able to identify, because we had access to several of these cohorts that also evaluated the impact of various social determinants of health, that indeed job and food security, health literacy, access to housing and a safe environment have been linked with absolutely severe outcomes in people with heart failure in general. And then there is also cardiac rehab that can be extremely effective for heart failure in general. So to summarize this part, here is a proposed way of performing a multidisciplinary management in people with heart failure, depending on each of these stages, starting with stage A and who are the critical team members. Definitely, as you can see here, primary care, it's the critical, a dietitian, and perhaps an endocrinologist, and then promoting what are the non-pharmacological and medical management steps that should be optimized in that stage. Stage B, now we can diagnose people in stage B by, testing and screening with these biomarkers. And then once we have that evidence, who are the team members at this point, perhaps including a cardiology, at least for in the background, but first optimizing all these steps, as I mentioned earlier. And then of course, as the disease progresses, yes, the medical management, it's more complex and definitely requires the cardiology involvement. So the question is, why should we integrate implementation science in the practice. And we've been talking about that in the diabetes field so much. I mean, we have all these guidelines. We update them every year. But the truth is that even if we look at the most recent data on the use of guidelines-directed therapy in people with diabetes, now it's still a very low number of people that are actually being treated according to the guidelines. And, you know, there are always a lot of reasons, whether access or, you know, inertia. But we need to understand that all this evidence, all the interventions and innovations are only as good as how and whether they are adopted. And they have to be adopted by us, the medical community, and they have to be adopted by the patients. Practitioners needs to be trained to use it. We need to provide the tools that will make everybody comfortable, not only in screening, but knowing what to do when a given you know, screening test. So we need to train all these practitioners and implement the way to do it. And then, as I said, patients, populations, tracking outcomes and see in real life. I know that many of you were mentioning that yesterday when I was talking to the fellows, that clinical trials versus real life, it's a huge gap. It's true, but we now are actually in the position to do exactly that because we have all the tools. We have the biomarkers, we have the electronic medical records to enable us to identify these patients and order these various strategies. And we have the tools to actually change the course in people. So in overall, this is kind of a schema of how we take the guidelines and we implement it into the clinical care through these various quality improvement projects that clearly are complex and requires, as you can see here, a lot of you know, collaborative work between the administrative infrastructure of a given health system, the practice engagement, the education, and using of the data in the best way to identify people who would most benefit of a given intervention or quality steps, and also to track the outcomes when this quality improvement process is in place. So now I want to end by sharing with you how we decided to do it at Michigan. And I have to tell you that it was not easy. Once we published the consensus, and particularly when both AHA and ACC have endorsed it, I, you know, reached out to our quality improvement team, which is pretty complex, and said we need to try to do so. We have the tools, here are the guidelines, let's see whether we can do it. And it was a long process. It took us more than almost a year. We do have a diabetes quality consensus. I had to present this data at multiple layers of oversight, need to meet with the IT department and with all these various EPIC groups to create you know, the infrastructure for such a process. And we also identified, well, my goodness, we are providing care to 90,000 people with diabetes at Michigan. We cannot screen 90,000 people, right? So then we identified the highest phenotypic risks, age, presence of renal impairment, other complications. And we started to go that way. And actually to exclude all patients with diabetes and heart failure who are part of the heart failure registry. At Michigan, once they are seen in cardiology and they are admitted in the hospital, they are automatically included in the heart failures registry. So we then screen our database and identified adult patients with 50 or older, both type 1 and type 2, because I showed you that type 1 is also risk factors, who were not part of the heart failure registry, never had a diagnosis of heart failure, and also had at least one of these other risk factors: obesity, hypertension, chronic kidney disease, or known cardiovascular disease. And did not have any BNP or pro-BNP measure in the last 365 years. So that's how we built our best practice alert. And if there is no anti-pro-BNP order, then we were able to create this infrastructure in which order sets are populated that the MA can actually click when such a patient is seen, whether in primary care, endocrinology, or nephrology. Again, cardiology are working with us on that, but once they are in the heart failure, they are already in stage C and D. And then we link this order set with this smart set of a diagnosis encounter for screening for cardiovascular disease. So to help our clinician, to bypass as much burden as possible, particularly in primary care. And I have to tell you that I was stressed initially, but the most enthusiasm I got working with our primary care physician who said, this is awesome. We want to do that. We want to know how to diagnose and we want to participate in this type of project. And so this is exactly, it's ready to go. We test the NT-proBNP. If people are under 125 and are under 7, again, aging, since then more data has emerged regarding the age effect on these specific thresholds. And our European colleagues were instrumental. Tony Baes-Ginis in Spain had done very elegant studies along those lines, as well as Jim Janotti. And then if they are above 75 years, the threshold of 450 was decided. And if it's normal, then we will repeat it annually. But if it's elevated, either above 125 or above 450, then automatically another, another link opens up for clinicians to allow them to see, are they on ACE/ARB? Are they optimally titrated? Do they have good blood pressure? Do they have an SGLT2 inhibitor? And if they are on an SGLT2 and the blood glucose is not elevated, are they on GLP-1? And also links them some of the medications that need to be avoided. And then again, a repeat NT-proBNP in 6 months, after which a trigger for echocardiography will be started. So that's the process that we are now starting. But we are happy to share with anybody, because at the end of the day, what we really want is to provoke, to give the best care to all our patients. And we are now engaging in several grand rounds presentation, and we're going to all the primary care clinics again to show clinician exactly what the EPIC screenshots will look like, to familiarize themselves, and then we also, of course, have the IRB in place, approved to track outcomes down the line, how the screening and the implementation of the the steps to optimize their treatment will track in long-term outcome in this patient. So as I said, it was a very interesting journey that started here in San Francisco in 2019. And actually before, through some of the studies that were of interest to me on the heart in diabetes. And we finally reached this stage when we have the tools, we have the biomarkers, and we have the means to change the course. And hopefully we will prevent stage C and D in all people with diabetes and fight all these complications. Thank you so much for your attention.
Thank you so much, Dr. Papoutsi, for this really fascinating talk about, again, two of the most common clinical conditions that we encounter, both for our inpatients and our outpatients, regardless of our discipline or specialty. A couple of quick questions from the audience. So Dr. Aras, who's one of our heart failure faculty, asks, with the overlap between diabetes, metabolic syndrome, and heart failure, is there concern about using BNP or NT-proBNP as a screening biomarker, since it can be falsely reduced in obese individuals?
Yes, this is a great question, and thank you so much for asking. And indeed, you are right. In fact, we do have additional threshold for the obese patients, which are much lower. But when you implement the guidelines into the clinical care, a certain level of pragmatism has to be kept in mind, because otherwise we will never be able to do anything. So we decided, in order not to be confusing, to start with the 125. But then again, obesity, it's part of the second step in which we try to make sure that for those particular patients, the optimization process will be even higher. But that you are right. We were debating about should we add a third threshold for obese, even lower than 125. And at least in this initial step, because of practicality and not confusing the primary care, we decided to go like that. However, we are tracking the outcomes, and definitely this is not set in stone. And I'm happy to consider additional suggestion because at the end of the day, we just want to make sure that we do the best we can for our patients. But thank you so much. This is a great point.
Thank you. Other questions from the live audience or the Zoom in-person audience? I have many. I think one question that came up, you talked about the emphasis on diabetes management as truly a multidisciplinary team approach. And I was really amazed and impressed by the work at Michigan that you did to really collaborate among multiple professions as well as disciplines, as well as your IT infrastructure to make this really seamless for providers. In looking at lessons learned from that kind of complicated experience, how would you advise somebody trying to advocate for their health system to essentially collaborate, co-localize care, and ultimately save costs and improve quality?
Well, that's a great question. And I have to say, this was not easy. I mean, it shouldn't have taken us a year, considering that we had all the evidence in place, but it's not easy to go over all these layers of oversight. Now, we do have a diabetes quality improvement that we have established there for many years. And that team has always been with a very large representation of primary care. Now, arguably, the primary care physicians are those who perhaps are the most burdened these days because they have so many things to follow and screen or test. And they have obviously the one that had been initially most, not quite resistant, but let's try to find a way to make it easiest and seamless. And then of course the IT department have their own priorities. So it did not come out easy, but I think that the level of engagement, the fact that all of our physicians groups, including our cardiologists who initially were skeptical. And I have to say that they were telling me, I don't want to suddenly get now 800 referrals overnight because we cannot keep up with what we have. But when they saw, the stepwise approach that was developed also together with them, they felt that that's actually feasible. Now, how it's going to pan out at the end, I don't know yet. I think that, and I don't know exactly what are the specific infrastructure details here at UCSF, but to me, it's basically the future. We need to work together. At a couple of years ago, we were at a meeting and we were with many cardiology colleagues who said, well, we own cardiovascular disease and diabetes. Nobody, we can take care of everything. And I said, well, I don't think that that's true. Nobody owns treating people with diabetes. We all have to treat them together because our goal is that we educate all clinicians and particularly primary care. There is no way cardiology, we are outnumbered with 37 million and growing, and with all these kids with type 2 diabetes who are growing into adulthood very quickly. That's the only way to, stop this curve. And whether a person with stage B heart failure gets to be seen by a PCP who is well trained and has all these tools at the elbow, that's best because it's the patient who is going to, have the treatment that they need. And it doesn't matter who prescribes it or who screens them. At the end of the day, why we are doing what we are doing, we are clinicians and we are researchers because we want to help our patients to have a better life. And that's the mantra. And I think it's once you talk to them and explain it exactly with the primary care, when they understood the potential and the fact that things can be done in a way that it's not super cumbersome and super stressful, they were all on board.
I also love how this consensus document that was, again, a terrific feat that you and your team put together, how it also outlines the importance of social determinants of health. And with the kind of two questions related to that, with the SGLT inhibitors taking kind of central stage in this patient population and some barriers to access those medications. How do you see that impacting the future? And then perhaps the other good news side of that coin, with the new price cap on insulin, how do you see both of these kind of policy and politics changes impacting the future of our patient care?
Oh yeah, those are great questions. So definitely, as you could have seen maybe on the screen, that we incorporate this as an important team member, obviously social workers and also family support. I think that educating the patient is so important because many of them, health literacy plays an important role. And actually speaking the language that a patient understands, it's critical. They need to be convinced why would they want to do that. And I'm going to give you an example when it comes to speaking the languages of a patient that we understand. And it's not related to heart failure, but it's related to foot ulcers, because we know that diabetic foot ulcers are the leading cause of amputation. And I was talking to my podiatry colleagues who are all saying, my goodness, we tell our patients to offload, and nobody's actually adhering to that. And then we decided, well, let's do a quick test. So we started a survey and we asked our patients, what do you understand when we tell you to offload? And you can't believe me that more than 60% had no idea what we're talking. But when you said you should use a cast, so your ulcers, it's protected, then it was a completely different story. So we need to speak the language that the patient understands. We need to understand their culture. And then speaking on the cost, yes, costs are an issue. But as I've shown you, it's not just SGLT2. You would be surprised that perhaps, and we published another trial that I had an opportunity to work on with our colleagues at Duke, with Chris Granger and his colleagues at Duke, called Coordinate. And in fact, when we randomized this, it was a typical cluster randomized pragmatic trial in which we randomized cardiology clinics to optimize guideline-directed therapy in people with diabetes that included, as I said, ACE, ARB, beta blocker, statins, and then, of course, SGLT2. And across, 90 cardiology practice in the entire United States at baseline, less than 30% of people with type 2 diabetes were on guideline-directed therapy that included ACE, ARBs, and statins or beta blockers, for instance. So it's more than just this expensive medication. But coming to that, I think that it's so important. And again, I have to say that the American Diabetes Association last year, and we were, working nonstop, first of all, to drive the prescription price of insulin to a single pay of $35. And we lobbied not only the Congress, but we lobbied many of the insurance and actually the pharma. And as you see, Lilly has agreed to do so even before the Congress has agreed to have, the single pay for insulin. But it was another extremely, rewarding experience. And we were able actually to add these medications for diabetes among the 10 classes of agents that are now part of Medicare negotiation pricing, which is another victory, and hopefully we are going to win that one. I know that pharma is fighting back, but hopefully, but SGLT2 and GLP-1 are part of those, and that's important. And so we are trying to do the best we can. I mean, some of these SGLT2 will become generic, so that's also so good. So, one step at a time, but with the reduction price in insulin, people can afford more medications as well. And then educating clinicians, educating patients. You would be surprised that a person is on a DPP-4 inhibitor already and they pay and says, I cannot afford another agent. But then we educate physician and patient, you don't need to take the DPP-4 inhibitor in this instance. So therefore your pays are less, but it's still a lot of work to do.
Well, a terrific talk that really went everywhere from basic science to clinical guidelines to implementation science to advocacy. Thank you so much for your talk today, and thank you so much for your visit.